Hi, my name is Dr. Michael Cohen, and I'm Medical Director of Endoscopy at Physicians Regional Medical Center in Naples, Florida. You may not know of Physicians Regional because it's not a famous medical center like Mayo Clinic or Johns Hopkins, but we do some pretty darn good work in our endoscopy department, and I'm very proud of it. One of the things I'm especially proud of is that the staff really enjoys education. So we decided to do a series of in-services about various topics that are pertinent to the endoscopy staff. And we hope you'll enjoy this. If you are interested in further in-services that we're going to produce, please subscribe to our YouTube channel, and that way you won't miss a one. Today's topic is portal hypertension and what you need to know. And the way this came about was we were taking care of a patient with bleeding esophageal varices, and we were having difficulty controlling the bleeding. I asked the nurses to get sclerotherapy equipment available in order to stop the bleeding, and they were a little bit uncomfortable because they hadn't done esophageal sclerotherapy before. And indeed, it's a technique that we rarely use nowadays, but I thought it would be a good idea to get familiar with it for the few occasions when we do need to use it. Well, if you're going to talk about sclerotherapy for varices, you really have to talk about varices. And if you're talking about varices, you really have to talk about portal hypertension because they're all interlinked. So without further ado, let's talk about portal hypertension and what you need to know. In order to understand portal hypertension, it's very important to understand the anatomy. As you can see in this diagram, the red arrow is pointing to the portal vein. And what the portal vein does is it brings venous blood flow from the intestinal system to the liver. Now, in various circumstances, the pressure in the portal vein may go up. When that happens, the blood backs up into various collateral circulations. And one of the most important ones is shown by the purple arrow, and that's the coronary vein. The coronary vein runs along the side of the stomach and links with the veins in the esophagus in order to get venous blood to return back to the heart, because as you recall, all venous blood has to go back to the heart where it gets oxygenated and goes back into the arterial system. In any event, when that flow increases in the coronary vein, again, that's the vein pointed out by the purple arrow. So when the flow increases in the coronary vein, it increases the flow into the esophageal veins and they become engorged and turn into esophageal varices. When the pressure in those varices is high enough, you can bleed. I like to use this analogy. It's like you're going down the highway and all of a sudden there's a big crash that cuts off traffic on the highway. Well, people start taking detours to side roads. Now, these side roads usually don't see a lot of traffic. So the traffic flows quite well normally. But all of a sudden, you're seeing increased flow because all the cars are getting off for the detour. Well, all of a sudden, that side road, which normally has quick traffic flow because it's seeing very little traffic, is seeing lots of traffic. It gets engorged with cars, and all of a sudden, the pressure on that road increases. So it's the same sort of analogy to what's going on in the portal venous system. So same thing here. You increase the pressure in the portal vein indicated by the red arrow, and that blood flow backs up and takes a detour to go back to the heart. And again, in this case, the coronary vein indicated by the purple arrow, and then the esophageal veins. So who gets portal hypertension? The vast majority of people who have portal hypertension have it because of cirrhosis of the liver. How does cirrhosis cause portal hypertension? Well, here's the analogy. If you think of the liver as like a big sponge, and then you take a garden hose and you spray water forcefully at that sponge, the water is going to trickle through because that sponge is soft and pliable. But now let's take a different situation where instead of a sponge, you're talking about a big rock. You're spraying the garden hose at that rock, and the water can't permeate the rock, so it just shoots back at you because of the increased pressure. Well, it's the same thing in cirrhosis, because in cirrhosis, what you get is a scarred down, rock hard liver, and the blood flow is impeded because of that rock hard liver. So it backs up into the portal vein, and as we saw in the other diagrams, backflows into the coronary vein and the esophageal veins. So who gets cirrhosis? In America, the vast majority of people with cirrhosis have it due to alcohol or hepatitis C or non-alcoholic fatty liver disease. Now, another situation where a patient may not have cirrhosis but still has portal hypertension is portal vein thrombosis. A thrombosis is a clot. And if we go back to our diagram, you can imagine if you look at that red arrow pointing to the portal vein, if there's a large clot blocking the portal vein, you can imagine that that pressure will build up and have the same effect as if you had cirrhosis. There are other rare situations where people can get portal hypertension that we won't really discuss today. Well, let's talk then about the consequences of portal hypertension, which is namely bleeding from esophageal varices. Here are some cirrhosis fun facts. Varices develop in about 5 to 15% of patients with cirrhosis each year. Of the patients who have varices, there's about a 1 in 3 chance that those varices will bleed. And the 6-week mortality rate for variceal bleeding ranges from 15 to 25%. So it's really a significant cause of mortality in patients with cirrhosis and portal hypertension. Well, how do we treat varices that are bleeding? Well, the best thing of all is to prevent them from bleeding in the first place. The treatments available for preventing a first variceal bleed are called primary prophylaxis, meaning patients who have never bled before, and we're doing some interventions to try to prevent them from bleeding the first time. There are various ways we can accomplish that. One is by using beta blocker medication. Now, beta blockers are medications which reduce the heart rate, reduce the blood pressure, and therefore reduce the pressure in the portal venous system. We use medications such as nadolol, carvedilol, and propranolol, all of which do exactly that. They reduce the pressure in the portal venous system. Another way to prevent a first bleed is to do band ligation of varices. We'll talk about the technique of band ligation in a few minutes. It turns out that both beta blocker medication and preventative band ligation are pretty equally effective. Now, each have their pros and cons. How about combining the two? Well, it turns out that that's not really recommended due to some studies showing that there are increased side effects when you do both techniques. So we talked about each technique, beta blockers versus banding, having some pros and cons. Let's talk first about beta blockers. It turns out that about 15% of people cannot take beta blockers because they have a contraindication, meaning a strong reason that they should not be using the medication, such as asthma, congestive heart failure, or extremely low blood pressure. Of the patients who do go on beta blockers, about 15% will require dose reductions due to side effects, which can include fatigue, weakness, shortness of breath, low blood pressure, or low pulse rate. Band ligation has its pros and cons as well. The downside of band ligation is that multiple endoscopies are required, and each carries a risk of sedation. Every time you do the band ligation, there's also the risk of developing an esophageal stricture or an esophageal ulcer. And even after eradication of the varices, you still need to do periodic surveillance endoscopies to monitor for recurrences. Well, how about somebody who actually has a variceal bleed? We can't forget the basics, which includes resuscitating that patient with IV fluids, blood products, and correcting any coagulopathy which may be present. Another part of the basic treatment for a bleeding variceal patient is IV octreotide, which is given for 2 to 5 days to reduce the pressure in the splanchnic circulation and reduce pressure in the portal venous system. IV antibiotics are given because it turns out that they lower mortality significantly in patients with variceal bleeding. We usually use a broad spectrum antibiotic such as ceftriaxone, 1 gram every 24 hours for 7 days. Once the patient has been stabilized, we have to do some sort of definitive treatment to try to stop the bleeding. Band ligation is generally the procedure of choice. There are times when we need to use a Blakemore tube, and we'll discuss the Blakemore tube in brief in a few moments. Sclerotherapy, as we touched upon earlier, and then there is the TIPS procedure, and we'll discuss each of these techniques briefly. Let's talk first about band ligation. As you can see on the photograph on the left, this patient has large esophageal varices. On the right, you can see where a band ligator has been applied to one of the varices. You can see that thin bluish band, which is the ligator, which is now fastened to the varix. We talked about use of the Blakemore tube. A Blakemore tube, and we're going to have a separate in-service on this, by the way, but the Blakemore tube is sort of a type of nasogastric tube which is inserted through the nose and into the stomach, usually with the patient endotracheally intubated. The Blakemore tube has 2 balloons, an esophageal balloon and a gastric balloon. We normally start by inflating the gastric balloon and by pulling pressure on the external part of the balloon coming out of the patient's nose, we snug it up against the cardia of the stomach and put almost like a tourniquet effect type pressure on the upper part of the stomach to prevent the varices from bleeding. What about sclerotherapy? Well, it looks like sclerotherapy in these days is only confined to history books. But as we'll talk about, there may still be a role for it. The diagram on the left shows band ligation of varices. You can see that there's a little cylinder type device that is fastened to the tip of the scope, which is loaded with rubber bands. By suctioning the mucosa of the varix and then pulling on a tripwire, you attach the band ligator to the varix, which is very effective in stopping the bleeding immediately and then causes a fibrotic or scar tissue reaction in the varix to flatten it out and prevent the blood flow in the varices. The diagram on the right shows sclerotherapy. Now, most of us are familiar with the sclerotherapy needle because we use it from time to time to tattoo polyp sites and so forth. It's basically the same technique, only instead of using dye to tattoo the polypectomy site, we're using sclerosing material which enters the vein and scars it down. It turns out that endoscopic variceal band ligation is very effective. And that's, for the most part, why sclerotherapy went away. It controls bleeding in about 90% of cases, with a rebleeding rate of about 30%. But the main thing is that compared with sclerotherapy, there is less rebleeding, lower mortality, fewer complications, and fewer treatment sessions. So it's clearly the superior technique. But is there still a place for sclerotherapy? Well, as you can see from many of these items on the screen, things come in and out of fashion. And turns out that sclerotherapy has kind of gone out of fashion. But as I mentioned earlier, I think there's still the occasional time and place for sclerotherapy. So yes, there is still a role for sclerotherapy. Now, the ASGE, the American Society of Gastrointestinal Endoscopy, their statistics say that sclerotherapy is about 90% effective in controlling active bleeding, which is very similar to band ligation. It used to be the gold standard until band ligation came around. So if you have a desperate situation, bring it on. There are various sclerosing agents that we use to inject into the vein. And those include ethambutol, sodium moreuate, sodium tetradecyl, polydocanol, and ethanol. It's not really important so much which of these you use, but the important thing is to become familiar with an agent, to make sure that your endoscopy department stocks that agent and that you know where that agent is located, how much of it you're supposed to be injecting, and so forth. It's a very unsophisticated technique. And again, the endoscopy staff is already familiar with the sclerotherapy needle. They're familiar with injecting things through the sclerotherapy needle, such as tattooing agents and Botox. So it's really not a very different skill set whatsoever. But the main thing is, again, just familiarizing yourself with whatever agent you wind up choosing to use and making sure that you have it in stock, you know where it is, and you know how much to give. So here's Cohen's guide to sclerotherapy. If bleeding is profuse and you can't keep up with the blood loss, you don't have a prayer to band that patient because you can't see where to band. So what are your options at that point? One option would be to do an emergency TIPS. Well, guess what? You have to keep them alive in order to do that. You have to keep them alive long enough to get them down to the interventional radiology lab for them to do it. So TIPS is a great idea, but you've got to get the patient hemodynamically stable in order to get them there. What about a Blakemore tube? Okay, not a bad idea. It's usually effective in stopping the bleeding, although it's obviously a temporary measure. And then what about sclerotherapy? Well, I look at it like this. When you're in that situation, what do you have to lose? You don't have to remove the scope to put the equipment in like you would with a bander. So you basically aim for where the bleeding is and hope for the best. And you'll be surprised at how often you can actually stop the bleeding with sclerotherapy when you're in a fairly desperate situation. Preparation. Again, this is why it's imperative to know how to do sclerotherapy. It's not that hard from a nursing or tech standpoint. It's the same skill set as tattooing. It's usually 0.5 to 3 cc's of sclerosant that we're injecting, and we normally directly inject it into the varix. So again, desperate situations, sclerotherapy for the reasons I mentioned, Blakemore tube, okay, that's really desperate. And the goal is keep them alive so they can make it to a TIPS procedure. So let's talk for a second about what is the TIPS procedure. A TIPS procedure is a bypass that's done through the jugular vein by inserting a catheter through the jugular vein down into the hepatic vein and basically connecting the systemic venous system with the portal venous system. So that portal venous system that's got all that pressure in it is now connected with a low pressure systemic venous system, so the flow will preferentially go that way instead of going into the esophageal varices. It's a clever way of making a better detour or a more preferable detour for the blood flow instead of going through the coronary vein and up into the esophageal veins. It's highly effective in stopping bleeding immediately from esophageal varices. So I appreciate your attention, and I hope you've learned something about this important topic of portal hypertension. And I can't wait to tackle our next in-service, which is going to be about the Blakemore tube. Take care. Bye-bye.